Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Right, so today I'm gonna give you a brief overview on adaptive trials as sort of a last little talk on multiple arms RCTs. Let's start with the definition as usual. We're talking about adaptive design. Adaptive design is basically a method that allows modification to the trial and or statistical procedures of the trial itself after its initiation without undermining validity and integrity. A mouthful, I would say, and we're certainly going to have a look at some examples on how this applies in real life. But it is becoming more and more valuable and more used in trials that we're coming across, particularly after COVID. So I think it's worth having a look at it. Now, let's go back to our last session for a minute. As you remember, we talked about master protocols, and I did mention something about adaptive design, particularly as applied to one of the three master protocols that we commonly encounter, particularly the platform trials. So if you recall, platform trials are trials that basically investigate multiple targeted therapy in a perpetual manner, normally in the context of, for example, a cancer or a disease, where there are also often a variety of subgroups due to molecular characteristics of the cancer, etc., etc. And when adaptive design is implemented in the context of a platform trial, we talk about APTs or adaptive platform trials, which is where we most commonly encounter this type of methods, this type of designs. But APTs is not necessarily equivalent to adaptive design. And when we talk about adaptive design, actually all we mean is, as you can see in this relatively simple diagram, that we are designing a trial and we are embedding a series of review methods within the trial that runs in parallel with the conduct of the trial itself that allow for adaptation on the design. Once the trial is then conducted fully, or at least some of the arms that are in the trial reach a conclusion, the data gets analyzed. This is in contrast with the traditional fixed sample design, where you start with a specific design, you conduct your trial, and then you do your analysis. You might have some interim analysis that are planned in it, but they're not as nuanced, not as detailed, not able to modify the trial itself as it's running, but rather just stop it or allowing it to continue, if that makes sense. So if you think about it in a sort of set of groups, within the group of randomized controlled trial, you got master protocols trials, adaptive trials, and in the middle of it, you've got adaptive platform trials. And for most of the rest of the lecture, we'll be talking about APTs or adaptive platform trials and some of the bits and bobs that go with it. So we said that adaptive trials allow you to make modifications to the trial itself. Those modifications can affect a number of things. Today, we're going to focus on two, particularly patient selection and subgroups, and we're going to briefly touch on enrichment and patient randomization, and we're going to talk about adaptive randomizations in the context of particularly one breast surgery trial. And there are many other examples out there, but these are the two that are most commonly used. And in order to understand how these two modifications, these two types of adaptations are implemented, we need to kind of have a look at what an intermediate outcome measure is, as this is kind of necessary for the trial to be adaptive. So when we talk about an intermediate outcome measure, we're talking about an outcome that allows for screening for emerging evidence of activity of a particular intervention. We'll talk about some examples that will make it a bit clearer. But basically, an intermediate outcome measure happens early and frequently compared to the outcome measure that you're actually looking at for the overall trial. And it is supposed to be on the causal pathway to the outcome measure that you're looking at in your trial at the end. I think an example will make it a bit clearer, and we're going to talk about prostate cancer, and particularly we're going to talk about a trial that we touched upon before, the Stampede trial. So Stampede trial is one of the longest sort of lasting platform multi-arm trials, and you can see a graphical depiction of it here. Started in 2006 and is still ongoing. The primary outcome of the Stampede trial is overall survival, and it is about metastatic prostate cancer. Now, as you can imagine, it will take a long time to get data about overall survival when you start recruiting patients in a trial like this. Years and years and years and years and years. And sometimes this is practical, but certainly if you are trialing 5, 6, 7, 8, 10 interventions, and you want to fairly rapidly identify interventions that are promising or not promising, it becomes very unpractical. And we did talk about different types of survivors before, so we kind of have to imagine how the investigators felt when they thought, well, how are we going to do this? We can't really wait 20 years before we start dropping arms out of a trial that involves 7 or 8 interventions. So if overall survival will take a rather long time, we need to choose something that's more common and happens early. So the authors decided to go for failure-free survival, or rather ironically, the acronym FFS. Failure-free survival is a rather broad definition, and basically means you've got prostate cancer, you've got some treatment, and we do want to keep the cancer under control. When the cancer is not under control and is progressing, then it means that your treatment has failed, and that's when you've got failure-free survival. This will happen much sooner than death, so it will allow you to kind of get a gist of whether your treatment is working or not much sooner. But it's still very hard to actually obtain a universal definition of failure-free survival. It is very difficult to measure in a timely manner when you are following patients up. So the authors decided to choose something that is causally linked and very easy to measure. And in this case, PSA is the simplest possible one. If you have prostate cancer that is metastatic and you are being followed up for a number of years and your PSA starts rising despite you being on treatment, well, it's probably because your treatment is starting to fail. It is an assumption, but it is possible. And I have simplified quite a lot of things here. But basically, this is the reasoning behind it. So you need something that will allow you to capture very early if what you're doing is going to work or not. And this is your, in this case, PSA. If you go on the website of the Stampede trial, you'll actually find a calculation tool that is available to classify your patient if they're having biochemical failure or not. It's called the PSA progression value calculator, and you can go online and have a look at it. So PSA, and generally speaking, treatment failure is a good example of an intermediate outcome, something that allows you to make assumptions about how treatment is going to go in the longer run and how overall survival is going to be. Obviously, it does have some pros because, again, you can assess things pretty quickly and rapidly during your trial, and it allows for adaptive changes to your trial. So it's PSA in patients that are treated this way is skyrocketing very quickly. Obviously, this is not working. Let's drop it. Something along those lines. But it does have quite a lot of cons as well, especially, I feel, in the case of the Stampede trial, because it is based on assumptions. You are assuming that a raise in PSA relates to overall survival. But if you're dealing with a pathology that is actually very, very slow progressing and that would not necessarily cause the death of the patient regardless, simply assuming that treatment failure will correlate to overall survival is not necessarily true. You can't necessarily make that assumption or assume that that assumption is actually reliable. And we did talk about it when we looked at diagnostic tests and particularly screening. Often, you rely on a particular type of test to detect a pathology very early, or detect that a pathology is progressing, like in this case, but that doesn't necessarily mean that you are going to detect patients that are going to die sooner, because that pathology might not catch up with them. It might be something else. So you're assuming in this case that PSA will relate to overall survival. And because you are making that assumption, you risk dropping arms prematurely, arms that might actually be beneficial to the patient for other reasons. So now that we've talked about the intermediate outcome measures, we can have a look at a couple of examples of how they help adapting trials. And particularly, we're going to talk about enrichment first. Enrichment is a technique that uses interim data to identify treatment that are particularly effective in some patient subgroups. To give an example, we're going to talk about breast cancer, and particularly another one of the oldest platform adaptive trials out there, the I-SPY2. In the I-SPY2 trial, patients with breast cancer are recruited and are given neoadjuvant treatment. So they're given various forms of different treatments before having surgery. And then they are followed up and operated on, and the primary outcome of the study is pathological complete response. And that is because we know that if patients have breast cancer, have treatment, and then they have a pathological complete response, when they're operated on, they get better outcomes. And that's the sort of overarching theme of the I-SPY2 trial. But the I-SPY2 trial subdivides patients into 10 different subtypes of breast cancer. And different treatments are tested in combinations with each biomarker and treatment. So some treatments are available only for certain subtypes of cancers. Some treatments are trialed on all subtypes of cancers, and then they are dropped or continued depending on how effective they are. To cut a long story short, when a treatment is tested in a phase 2 manner, so in the sort of initial stages of testing for treatment, those treatments can either graduate or fail across the length of the study. A treatment graduates when it is estimated to have an 85+% chance of being effective at inducing a significant difference in pathological complete response. It's dropped or fails when the chance of it causing a significant difference in pathological complete response is 10% or less. And this is decided very, very early in the course of the study. And you can see here on the left how in the I-SPY2 trial, they've already tried a massive number of different types of treatments. And based on a very quick, very early analysis, the authors were able to graduate some treatments to the next stage where we're talking about phase 3 trials, and fail some of the treatments that were absolutely not promising. And these can apply to different subgroup of patients based on the original biochemical analysis. The intermediate outcome measure that they used to do this is actually serial MRIs. So as they were designing this study, they realized that preoperative MRIs were actually correlating pretty well with pathological complete response. So they do MRIs at time 0, 1, 2, and sometimes 3 and 4. And based on the data they get across the neoadjuvant treatment, even before knowing what the primary endpoint is going to be, they are allowed to drop or graduate treatment to the next step, if that makes sense. Now let's talk about response adaptive randomization. Now, response adaptive randomization is kind of an evolution of what I just described to an extent. And it's a technique that allows researchers to change the frequency by which patients are randomized to one treatment or the other based on success likelihood. This is a technique that requires a lot of pre-trial simulation and planning in order to maintain sort of the overall reliability of the experiments that you're doing, in order not to jeopardize your results. To give you sort of a diagram of how this works, when the trial starts, you'll have a number of different treatments available to you and a control arm. In this case, we've got 3 different types of treatment. As the data start trickling in and patients get randomized, it becomes evident, based normally on interpretation of an intermediate outcome measure, that some treatments work better than others. And an algorithm that's been designed before the trial started starts changing the way patients are randomized, putting more patients in groups that are more promising, such as treatment number 2, and less patients in treatment that are less promising, or number 1. As the study progresses, some treatment might show themselves to be so inferior that the algorithm will just stop randomizing patients to that particular treatment and drop the arm completely. If, as the treatments go along in the study, they show themselves to have been so superior, then a treatment might just get promoted to the next stage or just deemed effective enough that it doesn't need any more patients recruiting in it. Again, they did this in the I-SPY2 trial. So using interim MRI data, patients across the I-SPY2 trial can get randomized in bigger numbers to a particular arm and in lesser numbers to a different arm. And as you can see here on the left, you can see how different the numbers are for arms that have started pretty much at the same time, and how quickly certain arms failed or graduated, for example. Now, obviously, I've talked about sort of chemotherapy drugs for prostate cancer and chemotherapy drugs for breast cancers, but what about surgical interventions? Are there any examples of adaptive design as applied to surgical interventions? Actually, I've not found much, despite what I would describe as a reasonably extensive research. I found a trial from orthopedics that's called START Reacts that has to do with non-repairable rotator cuff tears, and particularly the use of a balloon spacer. Now, I know Sam is an ortho wannabe, so he might correct some of the orthopedic inaccuracies that I'm going to comment on in the next minute or so. But basically, you have 2 types of rotator cuff tears: tears that can be repaired and tears that cannot be repaired. In tears that cannot be repaired, it is postulated that using a balloon spacer, which is a technology that has actually been around for a number of years, will make outcomes better. And it has been debated across the orthopedic community, as far as I understand, for quite a while, whether that's true or not. So a group of researchers designed this particular study where for non-repairable rotator cuff tears, they will put in one of these balloon spacers versus not putting in a balloon spacer. And the primary outcome will be an outcome questionnaire called the OSS at 12 months. They embedded what they describe as adaptive technology or adaptive design based on simulation models, whereby if the OSSs at 3 and 6 months are convincing enough that the treatment is working, or convincing enough that the treatment is actually not working, the study can actually be stopped. And there's quite a few editorials out there in orthopedics journals describing these as innovative and adaptive. To me, it looks just like an interim analysis as it was planned in the old days, but I appreciate they've done some simulation models to corroborate that, but I don't think is that revolutionary, if I might say. A further example of multi-arm trial that does use adaptive design to a certain extent is Rossini. I'm sure general surgical trainees have been subjected to recruiting for Rossini, which has been ongoing for a number of years. It's a trial that has to do with infection control and measures that are taken in the operating room to reduce the SSI risk. It started with a number of potential candidates, treatments that were deemed to potentially be effective. And as time went along, we actually realized that none of them worked. And based on very accurately planned interim analysis, a lot of those arms were dropped between stage 2 and stage 3. And we are now in stage 4, where basically the researchers are thinking about implementing new, putting into the trial new arms to test different technologies against controls that have already been recruited or are currently being recruited for Rossini. And to an extent, this is certainly a multi-arm, multi-stage trial, which does use adaptive design, particularly in terms of including and dropping arms that are not effective. So to sum up what I've just discussed, we talked about what adaptive design is in broad terms. We talk about an essential concept that allows you to implement adaptive design, which is the intermediate outcome measure. We briefly touched on enrichment, and we briefly touched on adaptive randomization. And finally, we talked about very limited surgical applications that are out there in the literature.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.